Good evening, sir.
Good evening.
Hi, Shank.
So I think I met all three people either virtually or physically yesterday.
That's right, Amrish. We are meeting.
Shank is there, Sujoy is there, Rajiv is there.
I'm sitting in Jaipur actually, Amrish.
Sujay was here in Delhi yesterday. Rajiv and I had a chat about something else. You and I had that ad board.
I know, it's crazy. It's a very small world also.
I know.
How are you, Sujay?
Doing well, sir.
Sir, with your permission, can we start?
Yeah, please, Prashant.
Manmeet,
Sir, it's live. I'm going to remove the cover now.
Chat about something else. You and I had that ad board.
I know.
Manmeet, just let me know when can I start.
Sir, you can start now.
Okay. Hello. Good evening, everyone. Once again, on behalf of Mankind Pharma, I, Dr. Prashant, welcome you all on this session where we are going to discuss about whatever happened in the latest international conferences on diabetes. As we understand, nowadays, because physically it is now not possible to take part in these conferences, so we are bringing all the highlights and major insights from these conferences at your screen. So this time we are going to discuss EASD, which is still ongoing. Today is the last day of EASD 2021. Just let me share with you about Mankind Pharma. Mankind Pharma has always been the philosophy for serving life with the help of quality medications, affordability, and availability across the country. It was established in 1995, the founder, Mr. R.C. Juneza, and has been running under the leadership of highly experienced management team. We have achieved #1 rank in prescription wise and #3 rank as a market value wise as per IQVIA August 2021. We are now nearing USD $1 billion revenue also. If we talk about R&D part, research and development part of Mankind Pharma, which is a very strong, we have now a very strong presence with the announcement of worldwide patent of novel anti-diabetic molecule GPR 119, where phase 1 studies has already been started. In these precedented times, in COVID-19 care, Mankind Pharma also placed 100 crore contribution towards our warriors, our corona warriors who have given life in these pandemic times. We always cherish this partnership in care, and we thank all of you who have joined us here for this scientific engagement. Now with this, let me please introduce you to our esteemed guest of panel, Dr. Amrish Mittal sir, Padma Bhushan and BC Roy awardee and head of endocrinology and diabetes department at Max Healthcare, which is a group of 16 hospitals. Dr. Shashank Joshi sir, Padma Shri awardee and chairman International Diabetes Federation Southeast Asia and dean Indian College of Physicians and endocrinologist at Joshi Clinic and Lilavati Hospital. Dr. Krishna Sheshadri sir, senior consultant endocrinology and diabetes in Apollo Hospitals and senior clinical and research lead Apollo Sugar. Director, Primer, which is a medical education company, and PAMS are not-for-profit medical organizations. Dr. Sujoy Ghosh sir, professor of endocrinology at IPGMER, Kolkata, and American Association of Clinical Endocrinology International Clinician of the Year 2021. He has also been awarded with WIDF Award for Innovation in Diabetes in 2021. With this panel, we have moderator Dr. Rajiv Kovil sir to moderate all this happening in this meeting. Dr. Kovil sir, who is the Chief Diabetologist at Dr. Kovis Diabetes Care Center in Andheri, West Mumbai, and Nanavati Super Specialty Hospital in Vileparle, West Mumbai. He is also founder member and secretary of United Diabetes Forum. So with this, I hand over this session to Dr. Rajiv Kovis, sir. Sir, over to you.
Thank you so much, Dr. Prashant. Thank you, Mankind, for inviting the best in class for this post EASD update. So we have four top endocrinologists from the country who's going to discuss. I think I'm going to have a rapid fire question round with them, because 45 minutes to an hour is a very short time to actually digest what happened at the 57th EASD, which actually happened in Stockholm, and unfortunately none of us could go there. I'll start off with a landmark study which comes from India. This is to Dr. Joshi and Dr. Mittal, who both are co-investigators in this particular study. To Dr. Joshi, to start off, what was the aim of the landmark study? Was it to find out the micro and macrovascular complication and the variation between cities? And what did we achieve at the end of it? Dr. Shashank Joshi?
Yeah, am I audible?
Yeah, you're audible.
See, landmark study is a ongoing study. It's a Sanofi-sponsored study. It's basically looking at diabetes complications, and in the current abstract which Dr. Kalra presented, they are looking at a 3-year nationwide multi-center observational study, which is looking at the real-life diabetes pattern management in India. It is basically to people between 25 and 60 years of age with diabetes more than 2 years, who are either or more than 2 anti-diabetic medications. And then they are looking at the patients every 6 months for 3 years for micro and microvascular complications. The current abstract which was presented at EASD was the difference between the complications of metropolitan versus non-metropolitan cities of India after 1 year. That was what was presented. And fundamentally, more than 6,279 patients were screened. And evaluable patients at the end of 1 year from 382 sites across India was 5654, means more than 5,000 patients. And at the end of 1 year, what was observed is that the age of participants, duration of type 2 diabetes, and baseline A1C of evaluable patients was very similar and comparable between metropolitan and non-metropolitan. But when we look at the 1 year microvascular complications, they were significantly higher from the non-metropolitan cities. That was 19.1% compared to 10.9% from metropolitan cities, which means the screening for microvascular complications and or occurrence of microvascular complications in the non-metropolitan cities need attention. Also, if you look at the comparison between 1 year data of macrovascular complications between metropolitan and non-metropolitan cities, it was 2.7 versus 2.8%, which means there was no difference. So this is very different from the rest of the world population. Clearly, it was seen that the neuropathy, nephropathy, retinopathy was significantly higher in the non-metropolitan cities with a statistically significant P ratio, while the macrovascular complications like was the same. However, there was small difference in the macrovascular component of acute coronary syndrome. Acute coronary syndrome was significantly higher again in the non-metropolitan cities compared to the metropolitan cities with a P of 0.0169. Rest of the complications were similar, like stroke, PVD, and acute coronary syndrome was the only differential which was seen, and myocardial infarction. So ACS was different, but MI, stroke, and PVD was not different. So it's a longitudinal study. And fundamentally, what was observed that the complex complication in the Indian population is neuropathy, both from metropolitan and non-metropolitan cities. And the disease progression of type 2 diabetes is basically giving us a cross-sectional prospective study, which is looking at all these things. So this is the insight on the metropolitan city. I'm sure Amrish will have his own comments.
Yes, sir. So over to Dr. Mittal, sir, your comments on why it was different between metro and non-metros, especially microvascular complications.
I guess obviously there may be more availability of specialists in metros, a higher proportion of people going to specialists, and maybe more sort of dedicated clinics that would look after the patients. Although this this sample has been taken from general practice very substantially. It's not just from specialist clinics. In fact, the main goal of the study was to look at overall diabetes care and progression. Yeah, I mean, obviously that can be the only explanation because overall diabetes is higher in the metros than in smaller cities. But the rate of progression of complications has to do then with aggressive management and screening. So I guess that may be the only logical explanation for this kind of difference. Nevertheless, it's a large study and it has shortcomings in its design and its implementation. But nevertheless, it's the first study of this kind, and the size of the population will actually give us valuable information as we go along. At the moment, this particular subset or this particular analysis only tells us that perhaps there's some difference in quality of care between metros and the smaller cities, because there can be no other difference really.
Thank you so much, sir. Anyone?
Can I ask a question, please?
Yeah, please, Sujay. Yes.
Sir, what was used to actually detect neuropathy? Because, if you look most of the studies worldwide, would this be the pattern that neuropathy is the commonest microvascular complication?
So neuropathy is one of the commonest. In fact, it is also present at the time of diagnosis very often. If you look at subjective neuropathic symptoms, I don't think they did NCVs and all. I think it was just standard of care. I mean, whatever we do normally and labeled as neuropathy, because they have not influenced in any way management. There is no protocol set. They're just profiling these patients. And yeah, so I think it is maybe based on symptoms as well as with the microfilament, not beyond that.
Right. Okay.
Yes, sir. Please, Dr. Sheshadri, go ahead.
What is interesting is, if you look at the overall macrovascular disease, there isn't much difference. But the AC is huge stuff. So I'm just wondering, what is the penetrance of statins? That could actually be a single big determinant of the difference in the complications, because if statins are where the difference between the statin use in the metros versus the non-metros may be actually a very important thing to look at. Because if you look at the whole macrovascular gamut, you will see there is not much difference between the non-metros. The ACS just jumps. So whether this is statin related, it will be very interesting.
I think it's worth looking at, but I believe compliance to statins remains the same pan India. People, the adherence to statins may be similar. Dr. Mittal, one question to you to start off about the twin cretins and tirzepatide. It's captured everyone's imagination across the globe. Do you think this is the answer? This is the next decade is for this twin cretins and GLP-1s? And is it the answer to everything? Is it the magic potion we are looking at?
So I wish that was true, but it is nevertheless fascinating. As we are just sort of digesting the data, literally, so to speak, from semaglutide, here comes tirzepatide in 2021 with loads of data and large number of studies spread across different clinical spectrums, like covering what we see in the clinic. So the concept, of course, we know what a GLP-1 RA does. We are aware of starting with, exenatide, going on to liraglutide,
Can we mute the rest, please, from the back end? Sorry, sir. Go ahead.
Yeah. So the concept, of course, was that in type 2 diabetes, it's the GLP-1 that's the problem. And therefore, if you use a GLP-1 RA, you get good results. And when we were initially discussing all the areas of incretin physiology, we always excluded GIP and said it's not of great significance in type 2 diabetes.
Go ahead. Please go ahead.
So basically, the whole concept of GLP-1 RA was based on the fact that this GLP-1 that is altered in type 2 diabetes. And it's that physiology we're trying to correct by giving something that stimulates the GLP-1 receptor. And of course, in oversimplification, but the bottom line is you're promoting insulin secretion and suppressing glucagon. That's how it works, So now, and we have this whole bunch of molecules that are available and we are all used to them. They never picked up in popularity beyond a point, but yes, they have a niche market, both especially liraglutide and now dulaglutide, once a week. Once a week has made a big difference, but considerations like cost and injectable nature of the molecule do result in some inhibition in its use. But then of course, semaglutide came, and semaglutide is not with us yet, but we know the data is exciting. We know that semaglutide given subcutaneously once a week, like dulaglutide, shows better results, both in terms of A1C lowering as well as in terms of body weight. And these are the two sort of most important areas that we look at in this group of molecules. And then, of course, the next advance is oral semaglutide, which again made a huge impact in the West, and we hope it will be soon available to us to use. But then, just as we were sort of assimilating this and moving on to clinical usage, there is this data on dual agonism, and that is the twin cretin, as this new sort of sexy molecule is a tirzepatide, which actually stimulates both the GLP-1 and the GIP. Now, how come we suddenly got interested in GIP? I mean, we were saying GIP doesn't play much of a role in pathophysiology of type 2 diabetes. And the fact is that when GIP agonists are used alone, they do very little. But when GIP-1 agonists are used along with GLP-1 agonists, then the impact is huge. So GIP versus GLP becomes a much potent combination, unlike just using GIP agonists alone. And that's why this concept of a twin cretin, that is a molecule that could stimulate GIP and GLP-1 both, has taken birth. And tirzepatide is a fine example of that, first example. So the first study that I'm going to talk about is SURPASS-2. There's a whole bunch of SURPASS studies, by the way, which are, I think, 10, if I'm not wrong, which are sort of underway, and we have results from many of them. So if I'm going to talk about SURPASS-2, it's interesting. It's a large study, firstly. There's almost 2,000. They screened more than 2,000, but they got about 1,878 people into the study. And the study was, the statistics are designed, the questions are designed in a way to give some positive answers for sure, which means that there's non-inferior 5, 10, and 15 milligram. Then there is a superior, and there is superior in HbA1c alone or in target HbA1c. So let's not go into that complexity. Basically, it compares 5, 10, and 15 milligram of tirzepatide with 1 milligram of semaglutide, all of these given once a week subcutaneous. That's important. So they're not compared with oral or anything. They're compared with once a week. Now, there is no placebo arm in this, right? And it was added to metformin at maximum doses, at least 1,500 milligrams, stable dose. Again, important to understand. The key point that I will raise here, of course, is why 1 milligram semaglutide for comparison with tirzepatide. I mean, that's how industry works, but the study is nevertheless very interesting. I would have expected a higher dose of semaglutide to be used in this for a genuine comparison. Nevertheless, since more and more data suggests that 1 milligram sema also works, I suppose it's okay, but that will be a question. Now, the patients were, as I told you, the BMI was more than 25, mean age 56 years, same duration of diabetes 8 to 9, A1C 8.6, like that. And mean BMI of 25 in Caucasians mean, what does it mean? It means that you have a mean body weight of 97 kilograms. Okay, so they were a big build population, right? Now, what happens when we compare different doses of tirzepatide to semaglutide without going into the actual numbers? In all of them, tirzepatide scores, okay, over semaglutide. So you find definitely it's non-inferior in A1C lowering, but it's actually 10 and 15 milligram are superior in lowering of mean HbA1c, body weight, achieving target A1C. And for me, what is fascinating is that at 20 weeks, the achievement of target A1C was really impressive in the group that was on tirzepatide. So these are people on metformin alone. And you added some different, I mean, either a semaglutide or 3 arms, which is 4 arms. One is semaglutide and 3 different doses of tirzepatide. Fundamental difference is that if you look at all the 3 arms of tirzepatide, you find that the A1C lowering is more than 2. So that's one very striking thing, 2.24, 2.29, like that. But that is big, adding one molecule and getting a lowering of more than 2 A1C in someone who starts with an A1C not of 12, but of 8.3. I think that is, for me, very striking again. And semaglutide, which was occupying the high pedestal, somehow had a 1.86 lowering of HbA1c, which is very good, very impressive. And it's only 1 milligram semaglutide, remember. So that's one. And similarly, in terms of body weight, they found that from moving from 5 to 15, you went from about 7 to 11, you can roughly say 7 to 11, easy to remember. 5 to 15 means 7 to 11 in this 40-week study. There was a reduction in body weight, kilograms, versus about 5.7 kilograms with semaglutide. There was some lowering in LDL, whatever. But this is the key. The sum and substance of the study is that there was significant lowering of A1C more than 2 in every group of tirzepatide, which was a little superior to that seen with semaglutide. Also, the other thing is that body weight lowering was, again, very impressive. I mean, with 7 to 11 kilograms is huge as compared to somewhat under 6 kilograms with semaglutide. A large study, 40-week follow-up. My question remains as to why 1 milligram semaglutide, but I don't think we'll get the answer for that.
Probably the answer is that tirzepatide still is not looking at an obesity indication and is looking at a diabetic indication, and sema is 1 milligram is diabetes and above 1 is probably obesity. Yes, Sujay, please add. Dr. Krishna, Dr. Shashank, please add. Yeah.
I'm not very sure whether at that point of time 2.4 was that popular when they perhaps designed the trial. That could be one explanation. And we now have studies to compare 1 with 2.4 to say that the A1C reductions are not very different.
Yes, so that's what I'm saying.
1 versus 2.4 is not very different, but the weight loss is different.
Absolutely.
So given the fact that this is above 2 and this is around 2, I still think tirzepatide 15 is going to be superior in terms of HbA1c, even if we had a 2.4. I'm just extrapolating. I might be wrong.
You're absolutely right. There are numerous studies, not numerous. There are several studies now out which compare 1 versus 2.4 and show a reasonable comparison. And like with all GLP-1s, the dose does not seem to make that much difference in the A1C as
but the weight.
Body weight.
Yes.
That's true for all of them. So probably 15 milligram tirzepatide will score.
But with the twin cretins, sir, the A1C seems to be a little bit different. Maybe there is some difference in the doses if you compare 5, 10, and 15.
I agree. Dr. Krishna, would you like to take that? And also, would you like to speak on the step 2? Because Dr. Sujoy just alluded to it about the step 2 study.
Right, absolutely. So what is interesting is, the holy grail is not just diabetes, but one of the things that tirzepatide was looking for is to establish itself firmly, one in the obesity space, but also in the NAFLD space. And that's something that, we haven't heard too much about, but we should probably hear a lot more over a period of time, because that's really where the goalposts are shifting. And the second bit is to just let me move back to the obesity space for a minute. Previously, we used to think about 5% as something, a weight loss is something that's very great with an oral agent or even an injectable, right? But now we're talking about 10% and with adequate combinations, 15%. And there are two ways that people that the pharma industry has approached it. One is bumping the dose of the GLP-1 RA. Remember, with SGLT2 inhibitors, you max out at 3 to 4.5 kgs, depending on the study you look at it. But with the GLP-1 RAs, and of course, in combination, Now, the first way is to increase the dose. You saw that with award 11, where dulaglutide was bumped up to 3 and then 4.5. And what the STEP studies do, and I still think that they have an issue with the FDA, but let's look at it. But the STEP study, and remember what was presented in the EASD was probably a post-hoc analysis. The original STEP study article was published by Melanie Davis in the Lancet in March, was looking at a higher dose of semaglutide. And what they did was very interesting. Let me just talk about the original study and then talk about subgroup analysis. This was looking at 1 semaglutide 2.4 versus 1 milligram, and what they did was they had about 1,210 patients randomized to either 1 or to 2.4 or to placebo. And remember, they had to up titrate it. So the placebo group and the 1 milligram group had 2 steps, and of course the 2.4 had to go from 1 to 1.7, and then had to go up to 2.4. They were evenly divided, mostly white, and the average A1C was 8.1, but the mean body mass index in this group was about 35. So, which is right in that place where you would start looking at bariatric surgery for many people. What we noticed was that there was a 7% reduction with the 1 milligram of weight, but a 9.6% reduction in body weight with the 2.4 milligrams. And interestingly, as was pointed out, that the A1C reductions weren't very different, as Sujoy pointed out. Minus 1.6 for the 2.4, and minus 1.5 for the 1 milligram. And remember that for the 2.4, there was about a 15 to 20% increase in GI side effects. No acute pancreatitis. But here comes the post-hoc analysis, and what they did was they looked at various subgroups, and they looked at the proportions looking at less than 6.5, less than 7. What happened when OADs were added? How many people reached 7%? How many people reached a weight loss of 10% or 15%? So the first thing was that when it came to A1C, as we talked about it, that there was not much difference between the 1 milligram and the 2.4 milligrams. And and interestingly, and this is something you see only with the GLP-1 RAs, you're going to see a majority of patients, about 60%, with the 1 milligram and 67.5 with the 2.4 milligram, reaching an A1C of less than 6.5. That's tremendous, considering that 12 years ago we couldn't do, even in a clinical trial, having 50% of the population reach an A1C of less than 7. And then if you look at it, even with no OADs in the background, about 70% reach an A1C of less than 7. What was even more interesting is weight loss. With the 2.4 milligrams, there were 45% of patients who had a weight loss of greater than 10% and an A1C of less than 7. Interestingly, 25% of patients on 2.4 milligrams had a weight loss of greater than 15% and an A1C of less than 7%. So this is really bariatric territory, folks. And if you start combining it with the other drugs, let's say with an SGLT2, with tirzepatide, what you're going to really get, with their amylin analog, which Novo is bringing, you're really getting a serious contender in the next few years for metabolic surgery. So this is the big way to look at these particular studies, that what pharma is doing is incrementally saying, if I increase the dose, I have a greater weight loss, right? And over a period of time, I'm going to add other agents to this. So you have people taking these drugs for a very long period of time, that you're attacking more than one pathophysiology. You're addressing weight, and you're edging out metabolic surgery. I think that's really where this piece of the puzzle is going. And what would be interesting in this whole thing is to look at where the NAFLD picture is coming. This is still not very, very clear, but I think that also holds the key. We know some data from LIRA. We know PIO is in the picture. We know terzepatide is in the picture. But I think that other than the obesity bit, it's a metabolic fat that is a liver fat that's going to take center stage in the next few years. So what you're going to see, increased doses, pushing for increased doses, and maybe some very smart combinations that includes the twin cretins or the tricretins or any other molecule that's going to come in on the way.
Thank you so much, Dr. Krishna. Dr. Shashank, would you like to add something on tirzepatide and step 2 and the step group of studies? Yeah, thank you.
I would play a little devil's advocate here. I think we are getting carried away. In diabetes space, these molecules are very wonderful. In pure obesity space, I would do it with a pinch of salt. What these molecules are doing is all the ectopic fat, as Krishna rightly said, is being taken out, whether it's from the liver, pericardium, or wherever it is. That part acceptable. So whatever is the abnormal fat or the sinister fat at ectopic sites is being chopped off or shaved off. That part I'll accept. In pure obesity space, all molecules have bombed and they have never really survived long term. Of course, liraglutide has still survived, but it's not used de novo for obesity, at least in India. Semaglutide has a hope, and all the hopes and the hypes after 5 or 10 years have gone away, except lifestyle. So, having said all this, as far as we say diabetes, stroke diabesity, I think it's a fair point that they definitely give us biomarker benefit. They definitely give us outcome benefit. I would go and transcend beyond biomarkers to cardiovascular outcomes and much more. When it comes to long-term safety of these molecules in pure obesity space, not with diabetes or other things, I think that is still a virgin area. And even though there are approvals in place, and the best came from, of course, some of the very compelling studies, initially by liraglutide, followed by semaglutide, as Amrish rightly said, I think it's still a long journey in the pure bariatric space. In the diabetes space, I give it. I think these molecules are here to stay. As Sujay said, that there is a difference in the dosing part of it. But as I said, that we are still on the learning curve. But this is a decade where we are fast moving from an SGLT2 year to a year of the unknown with all these novel molecules. Also remember that strong pharmacovigilance is the key. And when you up the dose, what type of unusual side effects they will play, only 5 or 10 years will tell. So I would still be a little skeptic from that standpoint.
Shashank, very well put in. Yes, Sujay, please go ahead.
I think I would like to highlight another bit. We've come about 15 years away or 20 years away from Accord and Advance, when we were scared to lower HbA1cs less than 6.5. Now look at Surpass. There's a group that achieves A1cs less than 5.7.
5.7.
So in future,
51% in Surpass 2.
Yes. So do we see in future the guidelines changing and telling us that if you can safely achieve A1cs of less than 5.7, that's the target? Sorry, I couldn't resist myself from asking.
No, that's something that you're seeing in all the GLP-1 RAs. Remember that as way back as 2013, when John Hughes presented the LIRA data, we were actually asking, are these patients actually going into remissions? But the question is, who are you going to de-escalate? Who are you going to say, let's say somebody has an MI and they're on a GLP-1 RA and they have an A1C of less than 6. Are you going to say, you know what, let me pull back because this is not recommended for these, or are we going to blink and say, you know what, they have reached 5.8, let's leave them there? I don't know.
So I think, Krishna, you make a very valid point. These agents are not de-escalated, which is why what Sujay is saying is very relevant, that we are getting to that 5.5 number and 5.6 number and 5.8 number. If there was any other agent, the FDA would have mandated a de-escalation, but this is not being done here. And this is where the pharmaceutical industry is hoodwinking us into an advantage of near remission. And that is why now you see this whole remission thing which has started is actually nearing that. And I think lifestyle and what Dr. Taylor has said is a very different thing. bariatric surgeons have said it's a very different thing. Industry is trying to compete with the Taylor group of remission, which is the lifestyle group, and the bariatric surgeons, saying that we have molecules which can actually go there. And that's where Sujay is actually opening up another area of discussion, which is the new definition of remission, only for 3 months, which is, according to me, very short a duration. To say that somebody is in remission, 3 months you're off medications and you're in remission is a little, too far-fetched. 1 year still acceptable. So I think that's something. But I think this debate will then go endlessly, Rajiv.
I know. Is diabetes a surgically resectable, reversible disorder, will become a medically reversible? Yes, Dr. Mittal, you wanted to add something. Please go ahead.
It's not about remission alone. The thing is that if you have molecules that have non or extra glycemic benefits, then you may want to continue them even if then there's no hypoglycemia or side effect. You may want to continue them at lower A1Cs also. It's like giving them in non-diabetics, like SGLT2 and sooner or later GLP-1. So that will also determine whether we continue or not. Because we're now
the cardiorenal protection, it will be like a statin.
So we're now seeing patients in practice who are maintaining A1Cs of 5.85. I never saw that. And should I reduce, should I not reduce? Then you gradually start reducing, but you're not sure. Especially if there's an extra glycemic component there, which is an indication for you.
True, sir. So let's move to another group of molecules, which has again captured the other part of our brain. And they started as anti-diabetics, then went into the cardiologist's hands, then went to the nephrologist's hands, and now it's everywhere. So Sujoy, about SGLT2 and the pre-specified analysis of the DAPA-CKD based on albuminuria. What's your comment and what's your take on it?
Right. So I'm sure the entire audience has had a look at the original DAPA-CKD study. And one of the things that strikes out about DAPA-CKD is, number one, you had people who had diabetes and you had people who did not have diabetes. And both groups were put on SGLT2 inhibitors. In terms of renal involvement, they had to have lower eGFRs along with albuminuria. Now, that essentially tells us that you are not including every diabetic patient who's got renal involvement, because we are now aware that even renal involvement in diabetes, whether true renal involvement, can be without albuminuria, or you can have non-diabetic kidney disease without albuminuria in patients with diabetes. So that chunk, which is almost about 50% of all diabetes and kidney disease, is essentially out of this particular study. So let's keep that in mind, because what happens if you did not have albuminuria and if you had diabetes and if you had low eGFR, this study does not actually answer that. The EMPA kidney will actually answer that. So if you look at this study, what the researchers have gone and done is they've gone for a pre-specified analysis in which they've categorized the study population into 3 groups. Those with urine albumin creatinine excretions of less than 1,000 to 3,500 milligrams per grams, and more than 3,500. What essentially would probably have prompted the researchers to do this study is that one of the most important postulated mechanisms of how SGLT2s work is by reducing intraglomerular pressure. So if intraglomerular pressure is reduced, you would expect albuminuria to improve and renal outcomes to improve. And what essentially this study did show to us was, if you categorize these individuals in these 3 groups in terms of the baseline characteristics and in terms of the outcome, whether you're talking about the renal outcome, whether you're talking about the heart failure outcome, whether you're talking about the cardiovascular death outcome, there is no difference between the groups. So essentially telling you, at least in these categories of albuminuria, with renal involvement, with or without low eGFRs, with or without diabetes, the benefit of SGLT2 inhibitor, here in question dapagliflozin, seems to be equal. So one of the things that the presenters have concluded in their last concluding slide, they say that the effects seem to happen independently of albuminuria. Now, I would like to slightly differ from that, because the group which had values less than 1,000, if you look at the median ACR, it was above 450, but less than 500. Now, in your and my clinical practice, that group is not the major group. You would predominantly find people with microalbuminuria rather than, ACRs above 500. Of course, you'll have a proportion of people who will have ACRs above 500, but there will be people who will have ACRs less than that. So what happens there, we really don't know. So whether that group, if we had included in the study, would have benefited that well, I'm not very sure. So that's the only hitch. I would have actually loved to have a group of people who did not have albuminuria at all, and a group who had only microalbuminuria, and I would have wanted to see the same benefits, because then two things. Number one, even in the non-albuminuric diabetic kidney disease, I would have been confident that this drug works. And even in the non-diabetic kidney disease without albuminuria, because if you look at this study, the albuminuric non-diabetic kidney disease, apart from ischemic nephropathy, everybody benefited. So these are probably the only two caveats in the study that I could make out, but great results. 20 years it took us after ACE inhibitors and ARBs to find a group of drug. And now we have another group of drug now, finerenone, which is also nephroprotective. So we are lucky.
So Dr. Krishna, Dr. Shashank, would you like to add to the legacy of dapagliflozin now?
One thing I would like to add is actually another study that was presented in the EASD that gives you the magnitude of what you're looking at. These investigators looked at the difference between type 1 and type 2 diabetes and the heterogeneity of renal disease. And type 2 nephropathy is actually a more heterogeneous disease than let's say type 1. And that's really the really interesting point when you start extrapolating the results of the various SGLT2 inhibitor CKD studies, that the type 2 being ahead. In the past, a lot of us would do a lot of type 1 studies simply because it's much easier to get results. But getting these kind of results in a very, very heterogeneous population, that's type 2. And that's where, where Sujoy's point about lower non-albuminuric nephropathy or very, very low albuminuric nephropathy, how does it function? It becomes very important. What would also be interesting is to see, and I'm sure this is going to happen, that someone's actually going to do an analysis of the subgroups that actually mattered in terms of for example, the architecture or ultrasound findings or other biomarkers that look at what is the nature of the renal disease. But we are learning a lot that type 2 renal disease is very heterogeneous, and the applicability of the CKD of the DAPA data across the spectrum is something very, very amazing.
Thank you so much, Dr. Krishna. Now the last 10 minutes, we're going to have a rapid fire round. And we're going to carry on from here itself, because some data from the COMPASS study on oral anticoagulants said that polyvascular diabetes is almost a polyvascular disease with risk factors. There was a presentation at this EASD. This is to Dr. Mittal, sir, because you are an expert in NAFLD along with all the others. You start this that there seems to be diabetes is a polyvascular disease, but now it's centering around the kidney, the heart, and the liver. These are organs which get hunted together, they crosstalk together. So you have patients with NAFLD who have high CKD have NAFLD, NAFLD have high cardiovascular disease. So you are going to a hepatologist, but then you land up with an angioplasty. You are going to a nephrologist, and then you land up with cirrhosis of liver. So there's a lot of cross play occurring, sir. So can you explain this to us, because it's getting more and more confusing with more and more data?
No, I think these things were probably there, but with the exponential rise in diabetes, they've become more overt. As I keep repeating ad nauseum, that basically we are all chronic care physicians now. We're not really endocrinologists or diabetologists, because you really cannot just manage glucose or one or two. You have to look at the whole picture. And quite clearly, the involvement of various organs in this whole metabolic process is far greater than we originally thought. And again, one of the things that I always say is that when In the old days, liver and diabetes was one paragraph in Williams. I'm talking of the 80s. And now you know that liver and diabetes is so big. Anyway, saying that these coexist for sure. There is no doubt that the presence of NAFLD, for example, does predict the risk of macrovascular disease very significantly. There's a strong correlation. So the same people who will have central obesity, same people will have diabetes, same people will have fat in the liver, which is turning into fibrosis, and the same people will have higher cardiovascular risk. So I think perhaps and one of the underlying mechanisms is insulin resistance as a very basic level, where you have, because of insulin resistance, that is a trigger for NAFLD to a large extent. But it's important to understand that it's ultimately the free fatty acids that are playing a role in the liver and the toxic accumulation of lipid. We won't go into that. A very recent study published just yesterday, day before yesterday, has again shown that lean NAFLD also has a very significant risk of fibrosis and poor cardiovascular outcomes. So we are sort of, all these organs, God had made them to be married to each other. We were trying to be very special by picking one over the other, but they're all linked. The good part, however, is that the management of all of them is basically the same, except when you reach the last state, when you reach fibrosis, when you reach an MI, when you reach, CKD, like end state. Otherwise, it's the same, isn't it? So it does not mean that we have to do different things for them. All of them require the same lifestyle measures, and probably newer molecules will help us fight all those. But one last line before I hand it over back to you is that at the moment, with all the exciting data on SGLT2 and GLP-1 with regard to NAFLD, it seems to be just squeezing out fat from the liver. It's not really, we are not clearly aware of any fantastic pathogenetic mechanism to explain why this is happening, and this is really going to lead to some huge benefit. Right now, we know it's squeezing out fat, and by that it reduces some inflammation also. But how much it will work in long-term fibrosis, we don't know.
When you said lean NAFLDs, Dr. Shashank Joshi and Dr. Sujay Ghosh raised their eyebrows. I'm sure they have something to say about it.
About lean.
Quickly, I'll say that, the NA part, the non-alcoholic part, a lot of people are getting allergic. And metabolic physicians are getting into it and calling it now MALD. And MAFLD or MALD.
Yeah.
That will become a more popular term very quickly. Just like cardiologists and nephrologists have infiltrated into metabolic space, you will see metabolic physicians and endocrinologists also infiltrating into the liver space. And therefore, the inter-organ crosstalk is now getting into inter-disease and chronic disease crosstalk. So I agree with Amrish completely on that. And I think we are ultimately chronic care physicians. And reversing one disease might reverse multiple.
Yes.
So it is not reversing, insulin resistance, as I said, is the core. You will not only reverse probably diabetes, but a little bit of hypertension, fatty liver, and many more other things. And it will definitely have a cardiorenal hepatic impact. Sujay.
I have 3 papers lined up actually, which hopefully I hope to finish before the end of the year. Essentially, we've got a cohort of people with polycystic ovarian disease, and we've divided them into the so-called lean and so-called not lean on the basis of the currently used parameters of obesity. And we've got matching non-PCO people who are lean versus not lean. And we've actually looked at their livers as well, looked at their liver fat, looked at their body fat. And essentially, this concept about lean, whatever, NASH or lean PCO is essentially because of the way we are defining obesity. But if we were actually defining them on the basis of percentage visceral fat or body fat, we find that there is no difference. And we've actually done frequently sampled IVGTTs in a significant number of these people and shown that these so-called lean versus non-lean PCO and lean versus non-lean NASH are identical in terms of their insulin resistance. And all the hepatokines, adipokines, and cytokines are identical.
Thank you. Thank you so much, Sujay. There's a question from the audience. It's about CHF, about heart failure and CKD. If they are so common, why is that SGLT2 inhibitors are not used early? Why is it reserved?
Oh, it is used early. In fact, it is going to be the first line drug.
It's
Replacing-
rapidly.
It is replacing metformin. In fact, metformin has a competitor. I was hearing ESD. In fact, it's still going on virtually today. Metformin has a genuine competitor and a threat in SGLT2. And with DAPA becoming generic, I personally feel that, there is a compelling reason in people at high risk, probably to even look at DAPA, or not DAPA in general, SGLT2 as a class, which is definitely inching because there is hard evidence. I mean, show me the evidence on metformin.
Very true.
So I think these are early use drugs for sure. They are going to be used earlier. I'm not advocating they should be the first line of pre-diabetics, but there will be data in that direction. But at least as of now, at least a second or third choice, SGLT2 is definitely instinct. No question asked about that.
Thank you so much. Dr. Sujay, this is the last question, and everyone a short comment about hypoglycemia. We had the HypoResolve study at the EASD. Now, everybody has been like bashing hypoglycemia because that seems to be one marker for cardiovascular disease and cardiovascular events. VADT and so many have shown that. Tell us something about the HypoResolve study, and does it kind of further strengthen the evidence against hypoglycemia? Is it a marker, risk factor? What is it exactly?
I wish I could answer that very clearly, whether it's an association or whether it's a cause-effect relationship. Essentially, it's a pretty big study looking at data for both type 1 diabetes and type 2 diabetes. The first thing that strikes out is that at least some events of hypoglycemia seems to be very, 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 very common in both groups. You would probably have not expected so much of hypos even in the type 2 cohort that has been described in the HypoResolve study. And the type 1s, of course, had very high prevalence of hypos, but remember, they had very tight glycemic controls as well. The couple of things that stand out in the study is in type 1 diabetes, particularly level 3 hypoglycemia was not uncommon. And it was only level 3 hypoglycemia that was associated with cardiovascular events. So type 1 diabetes, level 3 hypoglycemia correlated with CVDs, whereas level 2 or level 1 did not reach levels of statistical significance with cardiovascular events. Now, in type 2 diabetes, this was less strongly correlated with the CVD, but it seemed that neuropathy was much more common in people with type 2 diabetes with hypoglycemia. Now, let me try and look at it from two sides. First, let's talk about type 2 diabetes. So individuals who have neuropathy are likely to have autonomic neuropathy as well. So could that mean that they were having hypoglycemia unawareness at times, and therefore they were having more hypos? And could that mean that that autonomic dysfunction or neuropathy was the reason why they had more cardiovascular events? That could be one reason. Or it could be that people who have neuropathies have bad hearts as well. Or it could be that hypoglycemia was triggering cardiovascular events. The latter we will never know. And the challenge and the problem often we have is you don't know whether something is happening because that individual is more susceptible, and therefore you are having both the hypos as well as the CVDs more, or is it because you are more likely to have a CVD if you have hypos? But the rest of the things in terms of the microvascular complications, there was no strong correlation with the other microvascular complications. So that's again something which probably is expected.
Dr. Krishna, your take on HypoResolve and hypoglycemia and cardiovascular?
Joy has really, has summed it up very, very nicely. I just pick on a few things that I think. One is that the old age adage that talks about hypoglycemia begets hypoglycemia, and you saw that very well looked at in the 45 days before and the 45 days after the event in patients who had hypoglycemia. I think that's a lesson for all of us that when patients present with hypoglycemia, that's a time to sort of back off a little. The second thing is looking at whether these were selected as when you look at hypoglycemia, are we looking at when you are not able to manage glycemia well, or you don't have the sufficient amount of reflexes to get euglycemia, are you already selecting yourself into a cohort of a higher risk group is something that we need to look at. That is hypoglycemia a marker of you being in a higher risk group and therefore needing to back off? That is something that we will never know, but this is something that we need to think about. The third thing is when you look at the whole group, the question that also we need to ask is, where does glycemic variability feature the most? Since we have been looking at this for a long period of time, I think it's now the time to also look at and see, what is the relationship between hypoglycemia events and also glycemic variability. So these are the two things that I thought I will add to what Sujoy has already done very well.
Thank you so much, Dr. Seshadri. Dr. Shashank and Dr. Amrish Mittal, your final comments on hypoglycemia and hyporesolve study.
Hyporesolve had 60,000 plus patients. There are three major implications of these results. Number one, as both Krishna and Sujoy have said, hypoglycemia is clearly associated with negative clinical outcomes, both for type 1 and type 2 diabetes. The second consequence of hyporesolve was that occurrence of any form of hypoglycemia, any form, is associated with subsequent severe hypoglycemia.
True.
So it's a cascade effect. The third thing which was compelling from the results is that association of hypoglycemia with CVD is similar to estimates from other clinical trial cohorts like DEVOTE, EXAMINE, ORIGIN, VAT, VADT, ADVANCE. The only challenge is the definitions of CVD in other studies differed from hyporesolve, and they also included in the hyporesolve dizziness, shortness of breath, chest pain, and palpitations. So if you see from that standpoint, hyporesolve does give us some insights into this whole conundrum of hypoglycemia and negative association, cascade effect, and CV relation to it.
Dr. Mittal, your final take on it?
I think all has been said. Broadly, it's a large study looking at an association. It is along predicted lines by and large, I would say. And I think it's, for me, one of the most important things is the fact that it reiterates and brings home the point that if you get hypoglycemia, you keep getting more and more. As Krishna was saying, begets hypoglycemia begets hypoglycemia. And I think that's really important in terms of clinical management. Of course, we know the adverse long-term outcomes, but the fact is that when patients come to us in our clinic and to all those who are watching, with hypoglycemia, it should not be ignored there, especially the elderly. And there could be in for more episodes. Those who are prone, they keep getting more episodes. So you need to be careful with your glycemic targets and choice of agents in those patients. I think that's the single most important point, which we all knew, but it's still again come out nicely through this study. Last 45 days, next 45. So it's very, very clear that there's an association. So I think that for clinical practice, that's the most important message.
Thank you so much, sir. So all those people who are listening in, you all saved 1 week, 1.5 lakhs of rupees and exposure to so many people, because what you could have gained in 1 week in Stockholm, other than the sightseeing, you all could get in 1 hour. That's what, when the top 4 brains of India come together, that's what you get. Thank you so much, Dr. Joshi, Dr. Krishna, Dr. Sujoy Ghosh, and Dr. Mittal. Thank you so much. That was a wonderful session. Let me hand it back to Prashant and the organizers for their vote of thanks. Thank you so much.
Thank you, Koval sir, and thank you all the panelists, Shashank sir, Amrish sir, Krishna Shetty sir, and Sujoy sir, for this yet another wonderful session of EASD, which was telecast, within 24 hours of all the EASD highlights. Now, for the thank you note on behalf of Mankind Pharma, let me please invite Ms. Pallavi Paul from our marketing team. Pallavi, over to you.
Thank you, Dr. Prashant. So good evening, everyone. So continuing with the series of highlights, starting right from ACE, then ADA, and now EASD. This panel of such giants in the field of diabetes and endocrinology really enhances and adds up to the knowledge of our viewers. I would like to thank our panelists, Dr. Amrish Mittal sir, Dr. Shashank Joshi sir, Professor Dr. Krishna Seshadri sir, and Dr. Sujoy Ghosh sir, for keeping the viewers thoroughly involved and throughout the session. And this could not have been possible without our host, Dr. Rajiv Koval sir. The quality of question that he puts up really makes the session interactive and so interesting. Once again, thank you so much, sir. And I thank the audience for joining us. And we promise to bring such sessions in future as well. So thank you once again. Thank you so much.
Thank you so much, Ruchika. Thank you, everyone. Thank you. Bye-bye.
Thank you. Good night.
Good night, everybody.
Thank you, everyone. Bye-bye.